all to the Carolyn Farb Endowed Lecture in Neurofibromatosis. Before I get into the other introductions, I wanted to acknowledge Reggie Bibbs.
Can't hear you.
You can't hear me? Okay.
You're not on.
I wanted to acknowledge Reggie Bibbs, who's a lifelong expert in neurofibromatosis. He's been living with the disorder for more than 40 years, and has come up with his friend Luke and Gilio, who's right here, has come up with the Just Ask Foundation, which is raising awareness about NF for the general public. And he has a wonderful website called the reggiebibs.com. So I suggest that you go visit that. They've done an award-winning advertising campaign for neurofibromatosis. Now this is called the Carolyn Farb Endowed Lecture. And where's Carolyn? I'd like to acknowledge Carolyn Farb. She's been called the First Lady of Philanthropy in Texas, and well deserved. From medical research to children's charities and women's issues to the arts to education and the environment, Carolyn's efforts have raised in excess of $35 million for over 125 charitable organizations. Locally, Carolyn has raised funds for the Texas NF Foundation, which we have benefited from. Her fundraising efforts were primarily responsible for getting our NF clinic up and running and sustained. And because of those fundraising efforts and her interest in neurofibromatosis, the Carolyn Farb Endowed Lecture was established in, I believe, 1992. And each year we've brought a distinguished researcher or clinician in neurofibromatosis to give this lecture. Carolyn's received many honors, and one of the recent ones was an honorary doctorate in humanities from Northwood University. As an example of her fundraising prowess, she, along with another local icon, Marvin Zindler, raised more than $3.5 million in funds for research in breast and prostate cancer. And that funding went to MD Anderson. Now, I hope we can get the audio visual real quick, but I want to introduce Dr. Packard. Many of you probably know Dr. Packard. He's an acknowledged international authority in children's brain tumors and in neurofibromatosis. He's professor of neurology and pediatrics at the George Washington School of Medicine and the director of the Center for Neuroscience Research at the Children's National Medical Center. Dr. Packard's primary interest is the development of clinical and translational clinical trials for children with brain tumors. He leads multiple studies on national and at the international level for a variety of childhood brain tumors, including medulloblastic and low-grade astrocytoma and brainstem gliomas. He does this within the Pediatric Brain Tumor Consortium as well as the Children's Oncology Group, having major leadership roles in both of those organizations. Dr. Packard also researched the effect of treatment on the neurologic and cognitive outcome of cancer, including brain tumors, and his other major clinical and research interests in neurofibromatosis. He chairs the only national clinical trials consortium for children with neurofibromatosis and leads investigations of diverse disease manifestations, including neurofibromatosis-related gliomas, which are brain tumor-associated NF, plexiform neurofibromas, and cognitive deficits.
Thank you. It's really an honor to be asked to be at MD Anderson, especially to give this endowed lectureship, the Carolyn Farb lectureship. I want to thank you very much for all you've done for MD Anderson and for the field of neurofibromatosis. It's a pleasure meeting a lot of old friends. I've told people, here's my audio-visual person. That the last time I was here in MD Anderson was almost 20 years ago in the Baylor and other places, and it's great to come back. And it's good to see that you have electricity and you could actually give a lecture today. My path into neurofibromatosis is a little bit circuitous, and that since I've been doing child neurology, I'm a child neurologist, and brain tumor work, I've always been the neurologist who's been involved in different places with the neurofibromatosis program. But I never really took a major leadership role in those programs until there's musical until I thought the neurofibromatosis was transitioning from a diagnostic, discipline to a therapeutic discipline. So when I was first asked to come up and lecture, the topic was supposed to be on medulloblastoma. That talk I've given multiple different times. So I'm sort of excited to see how this talk turns out and be able to get it up. Because it is a newfound major interest and focus in my career. And mainly because I think we can start doing, at least attempting to do things positively for patients with neurofibromatosis in a therapeutic way. So as soon as we're up, we'll be talking a little bit about, initially about the disease, but then more about some of the clinical trials that are forming and some of the preliminary results of some of those trials. And that's about as much as I can stall. Can I find it? Thank you very much again. And again, it's an honor to give this lecture, the Endowed lecture. What I chose as a topic of this lecture, am I not plugged into the microphone? Is molecular-driven clinical trials for children and adults with neurofibromatosis. And we know that neurofibromatosis type 1 has protein manifestations both in children and adults. And the gene defect opens a window really for molecular-based therapy. Although that window, which was very restricted at one point, I think is much wider open now. Now, and our focus, at least mine and as far as the consortium, is on the treatable manifestations of NF. And these manifestations may expand as time goes on. But we're going to focus on plexiform neurofibromas, visual pathway, and other gliomas, neurocognitive deficits. And we're going to talk a little bit about the malignant peripheral nerve sheath tumors and how that fits into the consortium and our directions. Although a lot of that work has already been underway with the sarcoma groups, of which MD Anderson is a major player. It's a clinical diagnosis, and these diagnostic criteria were established by the NIH Consensus Development Conference in 1987, and unfortunately, really haven't changed since 1987, which is not a good incorporation of what we understand molecularly about the disease. And these are the clinical diagnostic criteria. And I think we've all seen this multiple different times, mainly based on the cafe-au-lait spots, some freckling neurofibromas, and a family history. And the vast majority of patients, up to 95%, can easily be diagnosed within the first 5 years of life using these criteria. The difficulty is that the criteria don't always take into account other things we know about this disease. And I think since MRI was widely utilized in children and adults with NF in the late 1980s and early 1990s, everyone has known about these areas of blotchy abnormality through the brain on the T2 weighted images, both in the cerebellum and up in the cortex. And these have been called by a variety of different names. I like focal areas of signal and intensity abnormalities. I hate the term UBO because I just don't think it does the disease or anybody any real benefit in saying that you don't understand the illness. But one of the fascinating things about these blotchy areas, which are thought to be vaccualizations, possibly some dysmature brain, is that they change over time. If you take a look at a young child, may have multiple manifestations, especially age 4 through the brainstem and other areas of brain like here and up here. But if you take a look at the child sequentially, at age 2 you can find many of the manifestations. They can ripen by age 5, and that makes a tremendous problem sometimes in determining what is a tumor and what is the normal maturation of the brain in the patient with neurofibromatosis. Then they move along and seem to start dissipating as your child heads to puberty, and many of them disappear by the time the child has gone through puberty. Now clearly these aren't tumors. They have to be carefully looked at as far as when you're talking about therapeutic implications of what you're doing for these patients. If you're not treating something that doesn't need to be treated. And because they're present in probably about 95% of patients with neurofibromatosis at a specific age, the window being somewhere in the ages between about maybe 3 and 7, they probably should be part of the diagnostic criteria. Although they start getting very confusing as we're starting to talk at the end of this about some of the overlap syndromes with neurofibromatosis. They may have neurofibromatosis like MRIs, neurofibromatosis like manifestations, that are named other illnesses such as Noonan syndrome and other things because other physical or phenotypic criteria really predominate. So these are some of the additional diagnostic criteria we may be thinking about in the future for NF, which again, it becomes very important as we go into therapeutic trials, knowing who we should treat and who we shouldn't treat, and the MRI being one. And the second one that I think is going to be an extremely important one to look at is a genetic testing. The initial genetic testing that was available for neurofibromatosis type 1 was pretty terrible. They looked at truncated mutations, they were commercially available, and this led more people than they helped. Now with a variety of different sequential studies, as listed over here, specific laboratories, Domestic's laboratory at UAB, Legis up in Belgium, can get 85 to 95% of patients who have confirmed stigmata of NF to show a positive gene mutation or gene deletion. The difficulty is knowing what is the sensitivity of these type of tests in patients that don't meet criteria. And the groups that are doing this work will tell you honestly that they don't know how many more patients they will pick up with a gene defect in these sort of borderline cases. Or in patients, for my concern, for children with low-grade gliomas, especially visual pathway gliomas, because of the way we treat them, we would like to stay away from mutagenic agents, alkylators, radiation, in the NF population. So we want to be very specific to know what the patient does or doesn't have NF, and maybe a genetic predisposition to mutagenesis. So this becomes more than just a theoretic issue. But right now, I'm not doing this as a routine screen on patients. However, in difficult cases or in those that I think it might make a therapeutic difference, we will probably use this more and more. And certainly it has some significant implications of amniocentesis and pre-birth testing, but then you go into a lot of technical issues of what you do when you find that information. And that's not what we're going to be talking about right now. Incidence of NF, one of the most common neurogenetic diseases, 1 in 3,000, occurring in all races and ethnic groups, in both sexes equally. Clinical manifestations, again, 95% or more can be picked up at age 6. One of the interesting phenomena of NF, and those of you working with in the field know this, that different things show up at different times. That the plexiform neurofibromas, some of them are considered congenital, especially the diffuse or the large plexiforms, whereas other tumors will show up at different age ranges. So you have to have an understanding of the disease and what you're looking for to try to make therapeutic decisions. And the other major problem with this disease is it's got such a remarkable variability in outcome. About 50% of patients will have mild disease, 20% will have severe complications. And at this point, other than some crude measurements like whole gene deletions or large gene deletions are more likely to have severe neurocognitive problems, we're not quite yet at being able to take the genotype and translate it into the phenotype. And since when we're talking about treatment, we're not talking about treatment for short periods of time, we're talking about chronic, lifelong treatment, it would be extremely important to know which patients are at risk for which problems. So there are many clinical issues with neurofibromatosis, cognitive, the neurofibromas, the gliomas, and we'll talk about these. And one of the issues that comes up as we take a look at how we're going to approach this, do we treat the symptom? Do you treat the actual lesion itself if it's symptomatic or not symptomatic? Is there treatment of good benefit for acute manifestations, but can it be used chronically? What is going to be the acute versus the chronic toxicity of the intervention? Is this a lifelong treatment? Possibly not. For optic nerve gliomas and visual pathway, it may be a very short-term treatment because these things tend to be active only in a certain time period. versus something you might have to do long-term, such as neurocognitive issues. And we have to deal with the problem of erratic natural history. Things start and they stop. How do you know something is working and all you get is stable disease that you benefit the patient? The other problem is, we take a look at the clinical trials issue, is how many patients do we have with a specific type of active disease that could be a candidate for therapy? We're following over 1,000 patients in our institution. I think we follow a similar number of patients with neurofibromatosis, both children and adults. How do you work with the numbers? Because it's nice to say I have 100 patients with gliomas, but only maybe 10 of those will be active. So at what age, what grouping deserves the treatment? That's going to be really difficult. And that's why the idea of the Clinical Trials Consortium was so important to me, and that's what we'll be talking about a little bit. We also have to be very careful that as we make predictions, that we're working off of databases that are often extremely skewed. The databases collect one type of patients, overestimate the type of illness, and until we really get population-based databases, we're not going to really know where we're going with this disease. And I think we also have to move from this issue of institutional assessment to a central review and make these therapies biologically based. Now, everything is focused on neurofibromin, the product of the NF gene. It's expressed across many different neuronal types, and it has multiple functions. As a neuro-oncology-oriented person, certainly we've looked at it as a tumor suppressor gene, but it has a lot of different activities of differentiating neurons, and it regulates other things within the cell. And this has given us an opening towards biologic-based therapy of a variety of different things. Now, I love this slide because when this slide was made about 15 years ago, we were thrilled because suddenly we knew all we needed to know about NF. Neurofibromin had a major role in deactivating the RAS system, and if you had an absence of neurofibromin, which is a negative regulator, you'd have more activated RAS, and you'd have tumors. This was where we were 15 years ago. I hope we're a little bit farther along now. The cutaneous manifestations we aren't going to spend a whole lot of time on. The cafe-au-lait spot we've seen. These large plexiform neurofibromas, the dermal ones, the multiple ones, are a major problem, especially in adults, but at this point is not a problem we chose to really delve into, although other groups such as Corp's group, WAB, are trying to develop ways to measure these and figure out ways to therapeutically help patients. One of the earliest trials in neurofibromatosis was actually based on this. It was Vic Riccardi's work, who was centered here. He did the first study, the cataphil study, looking at ways to not shrink them, but relieve the symptoms of the itch and maybe get them a little bit smaller. And that actually was the first clinical trial of patients with neurofibromatosis. And it's one of those forgotten trials that was done in the late 80s and early 1990s. But it did set the scene for a lot of other investigations. These neurofibromas are a heterogeneous group of lesions. They form behind nerves, and they're predominantly Schwann cells and fibroblasts. But we know, especially for the plexiform neurofibromas, there's a tremendous interaction between the different cell types. And you can't only have one cell type like the Schwann cell involved. You have the interaction with the mast cells and other cell types to develop a plexiform neurofibroma. We'll talk about the variable rate and how they get classified will not be what we'll talk about today. But essentially what I'd like to focus on are the plexiforms as what our first target is for therapeutic intervention. These overlap into the nodular plexiform neurofibromas, which involve the major and minor nerves, which involve the plexuses, brachial and sacral plexus, which tend to be diagnosed in adulthood, where the more congenital, larger lesions tend to be more of a pediatric issue. And these diffuse plexiforms are thought to be congenital. They're seen in approximately 25% of adults. And it's interesting, depending on what group you talk about, how many patients have these diffuse plexiforms. A study out of England, looking very carefully with CAT scans and other things, found that up to 60% of patients had deep-seated congenital plexiform neurofibromas, many of which were not at all symptomatic. And there's an interdigitating network of nerves and blood vessels. They can occur both externally, and the hard ones to diagnose them internally, unpredictable growth, and they also can be very disfiguring and disabling. Surgery remains the mainstay of therapy for the plexiforms, and we're going to talk about the non-surgical treatments. Difficulty in developing these trials was a major issue in getting even drug companies involved. Was drug companies would say, okay, I'll give you the drug, but how do I know the thing's going to work? Because you have a variable natural history, how do you know anything's going to work? These are slow growing, they're erratic, they're difficult to measure, and a stable disease a reasonable outcome in a growing lesion. And what are you going to measure? They're diffuse, they're all over the place. How are you going to measure these lesions? Well, this became a significant problem when we tried to do our first study, cisretinal versus alpha interferon, in a study that we did looking at two agents in the late 1980s that we thought were reasonable initial targets. Cisretinal acid being a maturation agent, alpha interferon, because we had nothing else to do, but it was an anti-angiogen, it's an anti-inflammatory agent, and we treated 57 patients. The interesting thing is if you took an 18 months follow-up, the vast majority were stable the way we could measure it, although some of those patients clearly were progressing and we couldn't measure it. We had a slight reduction in some of the surface measures, but none that we could convince anybody this was real. This was a study we did in Philadelphia, and the group that led this study in Philadelphia has never been able to publish this study because nobody believes the numbers. Nobody knows what stable disease is with this process, and this really crippled the field for many years. Although once again there was symptomatic relief in a subgroup of patients on this study. Probably a little bit better received study in the drug that I still use off-treatment, study of quite a bit is thalidomide, which was published in this with the Cleveland Clinic group as a variety of mechanisms of action. But these were patients, at least these patients we defined a little bit better of who would be entered on study. Patients had to have debilitating or disfiguring plexiforms. They had to be enlarging before they started. We enrolled some patients, and we took a look at patients, both adults and children, on this study. 8 patients had no change, but 4 patients we could show some degree of shrinkage, but less than 25%. And probably as importantly, 7 patients with 12 had symptomatic improvement. But there were toxicities involved with the use of thalidomide. Vinblastine and methotrexate is being used up in Philadelphia. We don't have the results yet. Impron, being used by Dr. Chikaki in Pittsburgh for a variety of different reasons. That has been a very difficult trial to enter because of the therapy. It has to be given by multiple intramuscular injections, but is slowly accruing and moving to phase 2. The big breakthrough study, we believe, is the farnesyltransferase inhibitor study that Dr. Wiedemann put together. We were part of this, which was the first DoD-funded study, Department of Defense study. This study is useful because one of the things we built in is a very stringent way that we are going to measure these tumors. And this was the volumetric analysis that they developed over at the NCR, where you could take a rough cursor around these tumors and then let the computer and do all of the rest of the work, and you could come up with a volume measurement for the tumors. And that's exactly how this was done. It was done by hand, but at least it gave us a volume of these tumors. More importantly, it was reproducible. If you did it manually versus what the tumor showed you, it almost came up exactly what you wanted to see. And if you took a look at it, and this is probably the most important thing, that once patients started growing, they tended to continue to grow on their curve for a while. So that if you had a therapeutic intervention in a growing tumor, and you could slow down that curve, it was a rationale for going on for further treatment. And the volume increase was significant, and not surprisingly, the volume increase was faster in younger children. The other thing that we had to show in this study, this is Dr. Wiedemann's data, is this was not just a function of body surface area, it was truly a growth in the lesion. It just didn't grow with you, it grew faster than you. Now, the target that Dr. Wiedemann used was neurofibroma. Again, neurofibroma having the problem with the deletion of an activating RAS. There was a tremendous amount of interest back at that time of looking at a different way to deactivate RAS. And it became clear that for RAS activation, there had to be a step called farnesylation. And there were a group of drugs, the farnesyltransferase inhibitors, which were the first target we were going to use in NF1 and plexiform neurofibromas. One of the difficulties with this is we may not have hit the right target. We might not have interfered with the part of RAS, because RAS has multiple types of receptors that was active in the plexiform neurofibromas, or for that matter, the gliomas. That is probably one of the reasons the studies haven't been as successful. But again, the farnesyltransferase inhibitors, neurofibromin is downregulates RAS, neurofibromin functions as a tumor suppressor gene, farnesylation is necessary, and the FDIs block RAS farnesylation, downregulating things. So this was a study that Dr. Wiedemann set up. And one of the more interesting parts of this study, it had a placebo-controlled group. So that half the patients would get the farnesylation drug, the others would get placebo, and then they would be randomized at the time of progression. What that gave us was a placebo-controlled arm for the first time of untreated progressive plexiform neurofibromas. And because of that, we've been able to do a series of studies that have moved on further using the same placebo-controlled arm as our control group and being able to do single-arm studies for patients. Now, the study on farnesylation has just been finished in the last year, and we're supposed to have data in the next few weeks about how well it did versus farnesylation, versus the FTI drugs. We've done a study using a drug called pirfenidone, which modulates a variety of different growth factors, using Dr. Wiedemann's control group in collaboration with the NCI, another DOD-based study. That's just been completed. A phase 1 and a phase 2 was done by Dr. Bobovic at Mayo Clinic. We did the phase 1, phase 2 in children. That, again, information should be coming out in the next few weeks about the efficacy of this approach. But we could not do this until we finished accrual on both studies and the placebo arm got full accrual, because we have nothing to compare it against. Now, what we have learned a lot more of, and many of you know this better than I do, is that RAS has multiple functions, but RAS also has multiple ways that you could potentially target it. And if RAS is the target, or the best target, for the plexiform neurofibromas, and farnesylation up higher was not the best way to attack it, maybe we could target some of the downstream functions of RAS. And these look at a variety of different ways of control of the RAS signal transduction pathway that we have talked about and started using in children with neurofibromatosis. And they've moved along from the tyrosine kinase inhibitors to farnesylation to the variety of different things that RAS does downstream. And these things are all potentially usable. There's a study already underway with Gleevec. There's another one that was contemplated with Tarceva, blocking this portion of the pathway. We talked about the farnesyltransferase inhibitor study. An interesting drug that blocks on this part of the pathway, lovastatin, that may not be the best chemotherapeutic approach for the plexiforms, is getting a significant play to try to reverse neurocognitive dysfunction in children with NF. The RAF inhibitors, sorafenib is in that area, and we'll talk more about some other drugs for optic nerve gliomas. And then the one that we have decided to focus on a great deal have been the mTOR inhibitors. The problem with the mTOR inhibitors, and this is a huge problem, is the question of whether, if we block at this level, if we're going to have a biofeedback mechanism block and get secondary AKT upregulation. And that goes back to the entire problem of what are you doing in a chronic disease? Are you trading off one problem to another? If there is some theoretic evidence that this will regulate, and we may be having more problems and less in the future, not only for the plexiform, but for other tissues in the body. So this is a big risk as we go further. And many of us think the real way that we're going to make progress is to hit multiple biologic targets. As we said, we have a consortium that is trying to do these studies. I'm the PI of this consortium. It's centered in the operations office at the UAB that is looking at all of these different areas, and we're going to talk about where we are with visual pathway gliomas and neurocognitive. These are the institutions that are in the consortium site, although over time we expect other institutions may become parts of our consortium as a dependent. Now, the Neurofibromatosis Committee has decided that its trial that is now open will be looking at rapamycin, although that trial is recruiting patients much faster than we thought it would be,
And we may be going very quickly to a second trial. One of the drugs we're looking at is sorafenib, although there's some issues of long-term toxicity that we have to get over. As we said, there are other trials underway that are either underway or being thought of for the plexiform neurofibromas, including an anti-angiogenesis trial at Mayo Clinic. At this point, it is doing adults only, the AZD trial. One of the issues with the plexiforms is if you treat them, are you going to lessen the incidence of them mutating? And there is quite a bit of question of what is the percentage of mutation into malignant peripheral nerve sheath tumors. They clearly were overestimated in biased registries. They increase with age to a point. They seem to peak around the mid-20s. Incidence is probably about 5 to 15% of all patients with NF1. Again, they're thought to primarily arise from the plexiforms, although we don't know that for a fact in all cases. And survival is relatively poor unless you can totally resect the tumors. And the role of adjuvant therapy is under study. This is some information given to me by John Parenthesis, who's part of the sarcoma group also. But we talk about this lifetime risk of 8 to 13%, and it occurring in any area of all the malignant peripheral nerve sheath tumors in 20 to 60% of those patients with NF1. And the question that has been raised by others, if you try to treat these aggressively, are you going to have secondary leukemias or myelodysplasia? And the major problem with these things is that we just haven't gotten good therapies for them. If you take a look at the overall survival rates for these malignant peripheral nerve sheath tumors, they're quite poor. Now, are there going to be, will our group, in collaboration with the sarcoma group, try to attack this problem? Well, there are a variety of different studies that are underway for newly diagnosed, but few studies for relapsed patients. And these are the proposed studies we're looking at for the malignant peripheral nerve sheath tumors. And we're hoping in the next few months that we'll have a study for relapsed malignant peripheral nerve sheath tumors, probably looking at mTOR-VEGF targeting, although other drugs are under consideration. One of our major problems is we're having the same problem with the same discussion as we use these kind of therapies. Are we going to unleash this biofeedback loop by blocking down here? Are we going to see AKT upregulation and more problems? And that is what we're all worried about as we're going into these studies. So we'll go through past. Now, the second target we want to talk to you about are the ophthalmologic issues. I think that everybody knows that children with neurofibromatosis type 1 are at significant risk of having optic nerve or other visual pathway gliomas. We've known this since the old CT days that these are large lesions. Surgical resection will leave you with a blind eye, but probably will take care of the problem. The difficulty in these lesions has always been this diffuse spread. Where did this tumor start or stop in the visual pathway? Where a patient has enhancing lesions of the optic radiations. What are we dealing with? Are these all tumor areas? We treat them as if they were, although obviously some of this kind of visual pathway spread is going to be dysplasia. And we have a variety of different treatments. But for incompletely resected lesions, we have very little in the way of good therapies. The carbovincristin is not a terribly good option for patients who have already failed it. It always comes up to the question, can you use radiotherapy in these patients? And then you have the issue of toxicity if you happen to use radiotherapy. What is the main reason we don't want to use radiotherapy? Because of the concern of malignant transformation, secondary malignant tumors, leukemia, vasculopathy, and enhanced neurocognitive damage because of the brain that's being caught up. And interestingly, the incidence is poorly documented of how often are you going to get into trouble because of radiation. And certainly some of our alternative treatments are not without risk, such as the alkylators that some people have talked about using. The two papers that probably talk best about the risk of secondary tumors, there's a study by Jenkins in '93, looked at 87 consecutive low-grade glioma patients, many of which were irradiated. Jenkins' group in Hospital for Children did a lot of irradiation, found that 10 of 87 died of progressive tumors, but 5 of those were secondary malignant tumors, all occurring in those children who were irradiated. A second study that was recently published, looking at the English experience by Sharif et al., looked at. It's the 80 accessible patients. 9 of 18 irradiated developed secondary tumors, 8 of 14 non-irradiated, and of the irradiated, 5 died of secondary nervous system tumors, 1 died of a vascular event. Younger children had an increased risk of developing these secondary tumors, and malignant peripheral nerve sheath tumors also occurred in the radiation corridor. So those are reasons we want to try to stay away from radiation. The largest experience with chemotherapy is with the carbovincristin in the NF population, and the response rate is about 60%. Disease control rate is not bad, but it's especially good in the NF population. But salvage after relapse, there are very few options. These are the old curves with the carbovincristin, but showing that it works not only in the visual pathway tumors, which is as the hard line, but also in some of the brainstem glioma tumors. But also, if you compare those patients without NF and with NF, the NF population has this very interesting proclivity that if you can treat them effectively and halt the disease early, that many of them will stabilize. This has been shown again by a study that Dr. Ader led here for the Children's Oncology Group, looking at only carbovincristin for those children who had neurofibromatosis versus a randomization for those children who did not. And once again, the main bottom line here is that children with progressive lesions with NF treated with carbovincristin, many of them will do well, but about 20 to 30% will relapse. And when they relapse, we have a variety of different approaches, but few have been of proven benefit. Vinblastine probably being the one with the best data, but again with very little clear-cut data of efficacy in the NF population. And a lot of the other drugs, such as temozolomide, which is an alkylator, or multiple alkylator therapies, things we like to stay away from because of the risk of leukemia in the NF population. Now, there's been a tremendous interest in using a variety of different biologic agents, mainly coming to work from the tuberous sclerosis work that at Cincinnati and other places, suggesting that mTOR inhibition would be useful against pilocytic astrocytomas, and they nicely showed this paper in tuberous sclerosis that they could show response, then taking off the mTOR drug, the rapamycin recurrence, and then response again. But there are other therapeutic targets for these low-grade gliomas, and this is where I really think it's going to be very exciting in the NF community. There are a variety of molecular abnormalities in high-grade gliomas. In the low-grade, NF is the most common genetic abnormality, and NF1 loss is activation of these pathways. But recent reports suggest that aberration of BRAF, a downstream target of RAS, may be one of our best targets for these low-grade gliomas. And BRAF activation occurs in these low-grade gliomas with resultant activation of the MAP kinase pathway, and maybe a novel approach. And this has been best shown by this group working in London that showed BRAF being a mechanism of MAP kinase pathway activation in low-grade astrocytomas, including those in NF. So that one of the things that I think you're going to be seeing a lot of in the time ahead will be trying to treat these patients chronic use of drugs that block BRAF, which are our drugs already in phase 1 trials, or even more downstream with the MEK inhibitors. And you need to stay tuned on these, but these are the targets that we would like to see exploited in the future. I'll just show you one possible way that these biologic therapies might work. And we used a combination at desperation of Avastin and CPT11 or irinotecan based on what was going on in adult high-grade tumors and having nothing else to treat for a group of patients that were progressing despite everything we did. And again, these have been used with surprising benefit, at least in short-term response rate, for patients with high-grade tumors. And for this reason, we use the same approach for a group of children with recurrent low-grade tumors. 9 of 10 have failed 3 or more graded regimens, and these were the regimens they failed, and about a half of the group had neurofibromatosis. And what was amazing to us is that we were able, with biologic agents, to see tumor shrinkage in 7 out of 10, and probably more importantly, showed that these long chronic patients improved documented visual acuity, improved hemiparesis. So here's a biologic therapy after multiple chemotherapies came in that seemed to work. And some of these were dramatic. This is a child with 18 months of age that did not have NF, but we've seen a similar response in a child with NF. This is a child that failed all of these different treatments. This was the pre-treatment MRI. This is the post-treatment enhanced MRI after 2 months of Avastin CPT11. This is the flare image. This is what it went down to. This child stayed on treatment for over 18 months, and now we're finally stopping because we don't think we can give more of the treatment because of some of the issues of proteinuria and blood pressure issues. But it just shows the power of these biologic agents as we move on to the future. And we do have some toxicity in this approach. But it suggests that biologic therapy could be an approach. And we have a lot of different ways to go about blocking these systems in children with optic nerve gliomas, and there's going to be a variety of those. Now, one of the issues we have with these gliomas is that sometimes it's very difficult to separate a glioma from a hamartoma. And I dare anyone to tell me if this is a brainstem glioma or if it's an area of abnormal signal within the brainstem. This patient we've been following for 3 or 4 years without any treatment. So these have been very difficult to figure out until they're enhancing, until there's clinical progression. Another, the brainstem being a particularly difficult area for us to decide who needs treatment and who doesn't need treatment. And now as we get into older patients, the whole issue of the cortical gliomas becoming more of an issue as we're seeing more and more of these pop up in the 15 and 16-year-olds and trying to figure out who needs a surgical resection and when in this population. So the more you learn about NF, the more you start learning you have to look for other things. Cerebrovascular accidents are certainly a problem with NF, and the question with them is if we have to radiate, are we going to increase the risk of cerebrovascular accidents? And the 1% or less of patients who develop Moya disease are an extremely problematic group of patients to treat. The last thing I want to cover in the last 10 minutes is the third major or the fourth major target, and probably one of the ones that we're most surprised that we're into right now, is trying to reverse cognitive deficits in children with NF. Not only treat them, but actually reverse them. They occur in anywhere between 30 and 65% of patients. These children have both nonverbal and verbal learning problems. People always thought it was only math, it was only dyslexia, it's all over the board. But the good news is the incidence of frank, severe mental slowing is in the minority of the patients. They occur in 30, and ADHD is concomitant at 30 to 50% of patients, and may be responsive to treatment. We've been involved in looking at early identification of these cognitive deficits, and what you can see is that you can identify a subgroup of children as early as about 15 to 21 months who are going to be running into trouble with NF1. And as we're looking at that, as we're knowing more and more, the attention difficulties are a therapeutic target, and there's no clear data on the efficacy of stimulants, and we have to look at drugs that might affect both attention and cognitive abilities. But many of the other things that we've been looking as therapeutic targets for plexiform neurofibromas and gliomas may actually be a similar way to target the cognitive deficits, because the function of neurofibroma has been noted to be very involved in cognitive development, and it's expressed early in development and later in development is restricted to neuronal tissue, especially in adults. And the same pathways that we are trying to target have similar downstream pathways in patients with neurofibromatosis. Now, the breakthrough came from work out of Seamus Silva's laboratory, where his laboratory out of UCLA showed that neurofibroma may affect learning by alternative pathways. And then a study that was published in Nature by Costa demonstrated that learning deficits can be rescued by drugs in adult rats. Now, these are drugs that are going through water mazes that are adults. These are not infants. And they were able to reverse visual spatial difficulties using drugs, initially a farnesyltransferase inhibitor and later lovastatin in these animals. So the real question, can we have a similar effect in children and adults, and can they be more generalized to other learning issues? And this has led to the issue of lovastatin initially in mice, where we talked about what was reversed by Dr. Silva in adult mice, and that these were able to learn tasks and to overcome some of these so-called fixed learning disorders. And the problem we've had, and this is a Catherine North slide, is a mouse is obviously not a child. So how do we translate what we've seen in adult mice where they have reversed learning problems to children? Now, we've talked about the NF cognitive phenotype, IQ, in the average range to low average, with some people having very superior intelligence, attention problems, visual and spatial, poor planning. They're not that different from the mouse, in that the mouse's main thing that was shown was in visual spatial type of testing. And these other things that patients have are more scattered, are more variable in patients. So the study that is now about to start with the phase 2 study of lovastatin in children with NF1, based on this data from Dr. Acosta, from Dr. Silva. The phase 1 study was done in our institution with Dr. Acosta, and we've been working on many of the kinks of the study. But the primary outcome measure will be visual spatial learning and memory and attention. And we are going to focus on those two with a variety of other secondary measures, which are purely secondary measures because we aren't going to be able to get answers in all of these areas. One of the issues as we go along this are the primary outcomes we're targeting according to patients. That's a good question. Are we going to be overwhelmed by the erratic nature of this disease? Is it clear that we're targeting the same things that Dr. Silva's group showed an ability to overcome? And are we going to be able to pick up these kind of challenges? As well, the phase 1 study is completed. The phase 2 is now open in February of 2009. Now, there is a study that has just been published in JAMA using a similar drug, a simvastatin trial, for patients with NF1, 62 patients, a double-blinded, placebo-controlled trial. And the conclusion of that study was that simvastatin did not improve cognitive function in children with NF1. And this is very worrisome to us, except this study is completely different. It's a different drug, but it's a similar drug. It was a much shorter term period, only 4 weeks versus 12 weeks. And this is most important. Children are not selected on the basis of cognitive impairment. So they took all children in this trial, those who had impairment, non-impairment, children with very low IQs and very high IQs. And our study will be focusing only on those patients that have demonstrable cognitive impairment. And because they used only a 4-week period, the control group showed a marked practice effect. So there's differences between the 2 trials. We hope the difference will be good enough or significant enough that we could show benefit. The next where that this is going to go, one of the things we talked about, we're using mTOR now for plexiform neurofibromas, also for the optic nerve gliomas in another trial, is the evaluation of the impact on the cognitive profile of patients with NF1 when they're receiving rapamycin. We may be hurting them cognitively while we're shrinking their plexiform neurofibromas. So the study that we're doing in our institution before we start treatment and after they get treatment for a different problem is looking at their cognitive issues. Because again, the complexity of treating neurofibromatosis affecting one system and detrimentally affecting another. Now, the last thing I want to leave you with is that neurofibromatosis really isn't an isolated entity. The condition, the phenotype is, but where this is leading in the molecular pathways is overlap to a variety of different syndromes. And one of the things that has always worried or questioned investigators is why did some patients with neurofibromatosis have congenital and other anomalies like thickened corpus callosum or migrational defects, while others didn't. And then also, if you take a group of genetic patients, why do some patients who have Noonan syndrome have MRI findings consistent with NF? And why do about 5% of NF patients have a constellation of a phenotype that looks more like Noonan's with wide foreheads and bulging eyes? I think the answer to that is becoming relatively clear that many of these syndromes, neurofibromatosis being one of them, but also Noonan syndrome and some other syndromes, really follow the same molecular pathway after you miss the genetic defect. So that sure, there's upstream issues that are important, but downstream there's some common things. And one of the things that have been started at the University of California, San Francisco, has been a hyperactive RAS kinase pathway clinic for patients with these syndromes, and one was starting in Washington and hopefully soon in Sydney, Australia, to try to pool information together that maybe that a therapy for one condition will be available and beneficial to another condition. So we are still clearly only touching the beginnings of where we want to be in clinical trials with MF1. We have a lot of ways to go with this condition. We have to really wonder if we're just hitting one target. Are we going to be successful? Are we going to have to hit multiple biologic targets? I do think there's a great future in the therapeutics of this to help both children and adults with neurofibromatosis. Thank you.